Good afternoon to you, ladies and gentlemen. This is O.P. Yadav, Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery, and we are in Chennai, India, on the sidelines of the joint annual meeting of the Asian Society for Cardiovascular Surgery and Indian Association of Thoracic and Cardiovascular Surgery. And it's indeed our proud privilege, a singular one, to have Professor David Taggart.
Thank you.
David is Professor of Cardiovascular Surgery at the Oxford University in UK and international authority on myocardial revascularization.
Thank you.
David, you are just fresh with your art 10 years, your parlays in the European Society and your publication in New England Journal. We expected a lot. Are you a little disappointed with the results?
Yes and no.
Okay.
I think what I would say is that the ART trial appeals to everyone. For those who are against doing more than one arterial graft, they will say that the analysis showed no difference at 10 years. And that is absolutely true if you look at the intention to treat analysis. The problem with that analysis is that actually 40% of patients got a different treatment from what they were allocated to. And they are what we call as treated, so what actually happened. And if you look at the outcomes in those patients, we saw that patients who had more than one arterial graft had a very substantial survival benefit. So the ART trial is, I would say, a confounded trial, because we had so many patients actually getting a different treatment from what they were allocated to that it makes interpretation of the results a little bit complicated.
Now, why they got different treatment? Is it patient-related, or was there something to do with the surgeon's experience?
So a very important question, and it was both of those things together. So when I said 40% of patients got a different treatment, that meant or includes that 14% of patients who were meant to have bilateral ITA grafts, actually the single ITA graft, 4% of single crossed to bilateral. But what is very important is 22% of single ITA patients also got a radial artery. And when we designed the trial, we didn't know at that time that having a radial artery would lead to better outcomes than saphenous vein. But we published a paper in the New England Journal in May of 2018 showing that if you have a radial artery rather than saphenous vein, you have substantially better outcomes. But we didn't know that when we designed the ART trial. And I will say one more thing about surgeon experience that I think is very important. If you look at the ART trial, if you look at the highest performing surgeon in the trial who recruited personally, did 416 operations. On an ITT, intention to treat analysis, that surgeon had a very significant benefit in terms of survival for 2 ITA over 1. So I think what ART tells us is that it is a more complex operation, and that the surgeon is very important that the surgeon doing that operation is very comfortable with the operation. So who doesn't? So if the mean crossover was 14% for the whole trial, in some surgeons the crossover rate was 100%.
Oh.
We published this in JTCVS, showing that some surgeons crossed 100% of the patients from bilateral to single ITA grafts. Whereas, I have just said, the highest volume surgeon, his crossover rate was 1.2%.
So from 1.2 to 100% was the variability.
Yes. This is why it's...
So if I were to ask you a provocative question, and it would help the new researchers, if you were to redo the ART trial, how would you redesign it?
So this, again, is a very important question. And I would say that the person who is answering that question just now is Mario Gaudino and Steve Freems, because they're leading the Roma trial. and they learnt from the ART trial.
Okay.
What they learned was that a surgeon could not just say he had done X number of cases, but had to demonstrate they really could do these operations. Because when we designed ART, we took everything at face value. If a surgeon told us, I can do bilateral ITA, we believed it. But some of these surgeons, as I've just said, crossed 100% of the patients from bilateral to single ITA grafts. So if I was redesigning the ART trial, I would do what Mario Gaudino and Steve Freems are doing in Roma, which is they want proof and documentation that the surgeon claiming to be able to do the operation can actually do that operation.
Well, David, you mentioned that as treated, you found the benefit for bilateral mammaries, not an intention to treat.
Correct.
Do you intend carrying the follow-up beyond 10 years to see for the former group as treated, the curve diverges further, and for the intention to treat, maybe at 10 years and beyond the curves would diverge? So are we following these patients?
So again, another very important question, and the answer is yes. So what we saw was that at 10 years on intention to treat, there was no difference in survival. But if you look at the composite of survival, myocardial infarction and stroke, at 8 years we begin to see a divergence occurring. So this is biologically plausible with the concept that the longer you follow patients and the longer the internal thoracic artery stays patent, the potential for improved survival and outcomes. So we are beginning to think, we have argued for a long time that cardiology trials which have a 1, 2 or 3 year outcome are completely inadequate, and that you should look at any trial you look at must have a minimum of 5 years follow-up, and even then it's interim analysis, because we saw in Stitch the survival benefit in Stitch for surgical myocardial revascularization did not appear until after 5 years. So that we increasingly believe the importance of long-term follow-up, and even at 10 years that may not be enough to really see the true benefit of any intervention. So the short answer to your question is yes, we will follow these patients for another 5 years.
Another one, off-take from your trial was the contraindications. Now, diabetes, insulin-dependent diabetics, increased wound infections, especially with the pedicle, we accept. But as John Puskas mentioned that he didn't find any problems with chronic obstructive airway disease, which in the ART trial was an incremental risk factor. So your take, what would be the contraindications for taking bilateral mammaries?
So this would be one of the few times I would disagree with John Puskas, a good friend and colleague, because I think there are definite contraindications to bilateral ITA grafts. I think definitely the presence of diabetes, insulin, particularly in insulin-dependent diabetes, and particularly with obesity. You can use bilateral ITA grafts if you have a diabetic patient, even insulin-dependent, who is slim.
Yeah.
But not a diabetic patient who's also obese.
Even if skeletonized?
Even skeletonized. We showed very clearly in the ART trial that if you skeletonize, you will reduce the risk of sternal wound complications. But even skeletonization in the obese insulin-dependent diabetes, there is still a clear signal of increased wound problems. And these are the patients who should definitely have a radial artery as a second arterial graft rather than ITA. In our experience, I think if you have patients who have chronic obstructive pulmonary disease, if they spend more than 1 or perhaps 2 days on a ventilator, this tends to blow the chest apart. So in our experience, we see chronic obstructive pulmonary disease also as a contraindication. And also there are slight markers of increased risk in female patients and in the elderly. Now, those are not absolute contraindications, but they are relative. And so what we know today, we know that for many patients, the radial artery as a second arterial graft will give at least probably an equivalent outcome to a second ITA graft. So that answer, that has to still be answered definitively. And when we did the radial database, when we looked at the 5-year outcomes comparing radial artery versus saphenous vein, we saw a clear marker of improved outcomes and superior patency. The patency of the radial artery at 5 years was 92% versus 80% for vein grafts. And all of those patients are being followed for 10 years. Mario Gaudino and myself are doing this just now, and we hope to report this within the next year. What was the 10-year outcome of radial artery versus saphenous vein? So there are still questions to be settled.
So, ladies and gentlemen, we just heard Professor David Taggart. We all know him as a man of science and scientific probity.
Thank you.
And he agrees that the ART trial could have been organized a bit better, where surgeons' experience is a very important parameter which was probably not as well factored in, and the choice of the second arterial conduit also made a difference. But there is sufficient evidence in the ART trial that bilateral IMA is beneficial, and the follow-up longer than 10 years may substantiate that claim. The Roma study, as a follow-up from Mario Gaudino, is also looking at the same issue. Chronic obstructive airway disease and insulin-dependent diabetics and obese individuals, he feels, are a contraindication, though females and elderly age group, we must exhibit caution. Thank you very much, David.
Thank you very much.
It was wonderful.
Thank you very much.
Thanks.
And thank you to the audience.